To open the next session on Meeting the Experts for Breast Cancer is a young and dynamic oncologist, Dr. Herdee Gloriane Luna, who will introduce the speaker on the topic, Palbociclib, Changing the Treatment Landscape of Advanced and Metastatic Breast Cancer in Asian Women. Dr. Luna is the research head of the section of medical oncology at the National Kidney and Transplant Institute. She is also a medical consultant and practices in the following hospitals, namely, the Lung Center of the Philippines, the Metro North Medical Center and Hospital, the St. Luke's Medical Center, and the Providence Hospital, all located in Quezon City, Philippines. She is a certified member of the European Society for Medical Oncology, a diplomate and fellow of the following societies: the Philippine Society of Medical Oncology, the Philippine College of Physicians, the Molecular Oncology Society of the Philippines, and the Global Cancer Institute. She graduated from the Faculty of Medicine and Surgery at University of Santo Tomas and completed her training in medical oncology from the National Kidney and Transplant Institute. May we call on Dr. Herdee Gloriane Luna to introduce the speaker for this session.
Good evening, ladies and gentlemen. I am Dr. Herdee Gloriane Luna, and I am honored to introduce our speaker for tonight, who will be delivering an exciting lecture entitled Palbociclib, Changing the Treatment of Advanced and Metastatic Breast Cancer in Asian Women. Our speaker is Dr. Senthil Rajappa, who completed his Doctor of Medicine in Medical Oncology at the esteemed NKTi Memorial Institute of Oncology, Bangalore. He served as a consultant in Apollo Hospitals, Chennai and Apollo Hospitals, Vijayawada for a short period of time before joining the University Teaching Hospital at Nizam's Institute of Medical Sciences in Hyderabad, where he served as assistant professor and associate professor for 7 years prior to joining this institute. He had been instrumental in starting the DNB program in medical oncology at the Indo-American Cancer Institute and Research Center. He was awarded the Best Teacher for the year 2013 by the Tamil Nadu Dr. MGR Medical University. His memberships include the American Society of Clinical Oncology, the European Society for Medical Oncology, the Indian Society for Medical and Pediatric Oncology, and Indian Cooperative Oncology Network. Ladies and gentlemen, let us welcome Dr. Senthil J. Rajappa.
Hello, everyone. Let me start by thanking Pfizer Philippines for asking me to speak on this topic, which is changing the landscape of treatment for metastatic ER-positive, HER2-negative breast cancer in Asian women. And here is the outline for my talk. We will start by reviewing some data on CDK4/6 inhibitors in the endocrine sensitive and the resistant disease. We'll quickly skim through the Asian data with CDK4/6 inhibitors, and I will specifically focus on data with palbociclib. We'll go through toxicity and then finally end with real-world data from India, which will include my own experience and data from some other centers in India. I hope I will not overwhelm you with information in the next 20 minutes as is shown in this picture. So let me remind you that in the pre-CDK4/6 era, what we used to do for patients with advanced ER-positive, HER2-negative metastatic breast cancer is use monotherapy with one of the endocrine agents. We always would start with ovarian function suppression and then add on an aromatase inhibitor. There are situations where you may want to use tamoxifen or the other drug being fulvestrant. Now, these were the choices for patients who were not in visceral crisis and would qualify for endocrine manipulation in the advanced setting. Now, these were the pivotal studies done with the CDK4/6 inhibitors, the Paloma, the Monarch, and the Mona Lisa studies with Palbo, Abema, and ribociclib, respectively. Now, these studies included postmenopausal women with newly diagnosed metastatic breast cancer. Now, it could either be de novo or you could have relapsed after treatment in the early breast cancer setting. Now, the trials randomized patients to a combination of an AI plus a CDK4/6 inhibitor, which could be Palbo, Abema, or Ribo, to just the aromatase inhibitor with placebo. Now, all the three studies were positive. The median progression-free survival was nearly double for the patients who took the CDK4/6 inhibitor compared to if you didn't. Now, you couldn't have gotten very similar hazard ratios compared to what you're seeing here, 0.56, 0.54, and 0.56. You couldn't have gotten better in terms of the similarity between the hazard ratios. The response rates and the clinical benefits rates was also similar between these three drugs. Now, the Mona Lisa 7, which is listed on the right extreme of your slide, is a little different from these three studies because it was a study done with premenopausal women. Of course, the clinical setting was the same, but they were all premenopausal who were rendered postmenopausal with the addition of goserelin here. Now, again, the result was very similar, nearly doubling of the progression-free survival with a very similar hazard ratio, which is 0.55. But the data that was updated from this study last ASCO also showed an overall survival benefit. So that was one of the earliest studies with the CDK4/6 inhibitors, which showed an overall survival benefit. We'll come to why some studies showed and some didn't towards the end of this talk. So for me, if you look at the typical postmenopausal lady with metastatic breast cancer, these drugs look very, very similar. They're all the same wine in different bottles, probably with difference in terms of toxicity, the efficacy being almost the same between them. Now, the other very clinically relevant issue that we look for is quality of life. So the other important thing that we learned from these studies is that these drugs do not negatively impact quality of life in the first line setting. Now, that's clinically very, very relevant. This is the data from the Asian subgroup in the Paloma-2 study that we just reviewed in the earlier slides. Now, a small fraction of patients in these studies were from Asia. You can see that about 64 patients were on palbociclib plus letrozole, and about 28 on the placebo arm. These were the APAC patients compared to the overall population listed on the right side. Now, remember that there were some white population or non-Asian populations who were also included this, and the data I'm showing you is only for Asian patients. Now, if you look at the progression-free survival for Asian versus non-Asian, absolutely no difference. The curves are one on top of the other. The continuous line is for Asian patients. The dotted line is for non-Asian patients. Again, the hazard ratio very similar, 0.55 and 0.57. So this is data to show that the drug was equally efficacious in Asian patients as in non-Asian patients. Now we move on to the endocrine resistant population. Now you could have patients who were primary endocrine resistance or those with secondary endocrine resistance. So these studies were very similar to the first set of studies that we reviewed, except that the endocrine partner in this study set was fulvestrant, unlike AI in the first study set that we reviewed. Now, these were patients who had progressed on at least one prior line of hormonal therapy or had relapsed very early after their adjuvant endocrine therapy. So the trial randomized patients to palbo, ribo, or abema plus fulvestrant or to fulvestrant alone. Now, again, when you come down and look at the progression-free survivals, the difference between the arms is almost similar. The hazard ratio is almost similar, though a little better for palbociclib here. But what I want you to see here is that the absolute numbers in terms of the progression-free survival is very different between these sets of patients, 11.2, 16.4, and 20.5. Isn't that a little surprising? Certainly not. And the reason why there is a lot of difference in the numbers is because the kind of patients who went into each of these studies were quite different. Now, the patients who went into the Paloma study were more pre-treated than patients who went into the Monarch or the Mona Lisa study. Now, these studies included both pre and peri and postmenopausal women, but remember that all of them had to be rendered postmenopausal before they went on the combination. If you look at the Paloma study, a third of patients had previous chemotherapy for advanced breast cancer, while in the Monarch and the Mona Lisa, none of them had had any chemotherapy. A third of all patients had also had 2 or more lines of therapy for advanced, while it was lesser for the Monarch and the Mona Lisa, right? 85% of patients in the Paloma had had an AI in any setting previously. It could be in the metastatic or in the adjuvant setting, while those numbers were lesser in the Monarch and the Mona Lisa. And a very important clinically relevant point is that in the Mona Lisa study, this was consisting of patients, half of whom were absolutely endocrine treatment naive. That means they hadn't received any treatment for their advanced breast cancer. So it was half of patients who hadn't had any treatment at all for advanced breast cancer. It was like a first-line study for half of them and second-line study for the other half. So there was a lot of heterogeneity in terms of the inclusion criteria for all of these studies and hence the patients. And that's exactly the reason why you're seeing so much of difference in the absolute numbers as far as the progression-free survival, which is ranging from 11 months to nearly 20 months. So this needs to be kept in mind when you're interpreting these numbers. So lesser the lines of treatment previously, the higher the progression-free survival. The lowest number of previous lines of treatment was in the Mona Lisa, and that's exactly why you're getting that high number in terms of progression-free survival in the Mona Lisa study. But the other important and clinically relevant issue from these studies is that the Monarch and the Mona Lisa study, which were again updated last year, showed an overall survival benefit, while the Paloma tended towards an overall survival benefit in patients who had secondary endocrine resistance. Okay, so this is another important issue to remember from these studies. Now, why is this lack of overall survival benefit in the intent to treat population? The primary reason, as we discussed, is because the trial populations were absolutely different. Now, if you wanted the Paloma study to actually show you an overall survival benefit, and if you wanted to do an 80% power calculation, you would require more than 700 events compared with the 46% power resulting from the 521 events and patients that you had seen so far. So that's the reason why this study did not show an overall survival benefit, but the other two showed. So this is something that we again need to keep at the back of our minds. And this is probably the explanation for why the Paloma study did not show an overall survival benefit while the other two showed. So again, are they the same wine in different bottles? I still think it is the same, but for the toxicity between these. So we started speaking about wine, and too much of anything can actually be a toxicity. And hence, what are the toxicities with Palbo, Ribo, and Abima? Now, for Palbo and Ribo, typically what we see is bone marrow suppression. Now, this is very, very transient, as they call as paper toxicity. A significant proportion of patients, nearly 80%, would have some suppression in the white cell count, and some of them even in the platelet counts. But this is very transient, and almost all of them get out of this neutropenia during the 1 week break that you give during dosing with Palbo or Ribo. The other clinically relevant side effects of ribociclib include liver toxicity and QT prolongation, which is not the case with Palbo or abemaciclib. Now, when it comes to abemaciclib, the dosing is continuous, in contrast to Palbo and Ribo, wherein you have 21 days of dosing and a week gap before you start the next cycle. The other important side effects of abemaciclib include GI toxicity, which can be diarrhea and abdominal discomfort and pain, which is very, very important, especially when you are dosing slightly elderly women with these drugs. Now let's come back to our Asian population and look at what is the toxicity in these patients. Now, as you see here, as I have highlighted on this slide, you see that the incidence of grade 3-4 neutropenia is higher in Asian compared to non-Asian, and also the general leukopenia rates are higher. But does it mean that the incidence of febrile neutropenia was higher in Asian patients? The answer is no. Whether you saw Asians or non-Asian patients, the incidence was not very high. It was 4.6%. Now, only 3 patients, but since it was a small number, it amounts to 4.6 patients. But in the non-Asian group, it was 4 patients. So though the incidence of marrow toxicity is slightly higher, you don't get a significantly higher incidence of febrile neutropenia in these patients. What about the relative dose intensity and dose interruptions? Again, these were higher in Asian patients compared to the non-Asian patients. But again, a very clinically relevant point that one needs to consider is that even though the dose was decreased, these patients did have an outcome that was absolutely similar to the non-Asian patients. So if you decrease the dose for the sake of a toxicity, that does not have an impact in the efficacy, and the outcome remains the same as expected. Now, this is how you use the drug. This is monitoring for patients with Palbo, Ribo, and Abema, and this is the monitoring that you do in the first 6 cycles. Now, just look at this table. You see that the table for Palbo looks the least crowded, which means that is the drug for which you need the least monitoring. All that you need to do is CBC. But when it comes to Ribo and Abema, you need to do CBCs, of course, and liver function tests, electrolytes, electrocardiogram for ribociclib, and liver function test for abemaciclib, because there are some very clinically relevant toxicities which may be missed if you did not do the other tests for monitoring toxicity. So this is how I usually show this issue. Now, this is probably the shortest love letter from a cardiologist to his girlfriend. This should not happen when you're using ribociclib especially. So beware that it can cause some arrhythmias, and you have to be very cognizant of this when you're using ribociclib at least. Now, the question as we are listening and discussing this data is that does everyone need a CDK4/6 in the upfront setting? The answer is probably not, but unfortunately, we don't know who is that patient who does not need it. So let's look at case 1 and case 2, very contrasting cases. Case 1 is a very young lady who relapsed after her initial therapy for early breast cancer, and with a short 1-year disease-free survival comes with liver metastasis, bone metastasis, and a Ki-67 that initially was 50%. That's aggressive disease with some visceral involvement. Look at case 2. It's an elderly lady, 65, who had stage 1 tamoxifen, a disease-free interval of about 12 years, and after that relapsed with just a couple of bone mets and 1 lung met, something that we will refer to as low-volume disease. Now, these two are very different. It's very easy to say that case number 1 will certainly benefit from the addition of CDK4/6 inhibitor, while case 2 might have lesser benefits. But do we have real evidence to say that case 2 will have lesser benefits? The answer is probably not. So in the absence of clinical trial data, some patients may do well with an AI alone. Now, who are these patients? These are patients with long disease-free intervals, low volume, bone-only disease, low-grade disease, less aggressive biology, but there's no clear evidence to say that these might actually benefit lesser. So the simple rule is, if your patient is fit, your patient has access to and qualifies for a CDK4/6 inhibitor, my opinion is that that should form a part of the combination that you will use upfront for these women with advanced metastatic breast cancer. right? So that's my view on this particular issue here. So summarizing the trial data, which is the first part of our talk, CDK4/6 inhibitors improve progression-free survival in the first and second line MBC, which also translates into an overall survival improvement. The outcome improves irrespective of the pre-treatment, menopausal status, endocrine sensitivity, and the site of metastasis. Now, we didn't have time to discuss about biomarkers. Again, it's important to understand there are no biomarkers to predict the benefit or the lack of it with these new set of drugs. Now, again, we did go through some data for this. The trials cannot be and should not be compared because the trials contain differing populations and the definition of subgroups that were analyzed were absolutely different between these studies, and hence you should not and cannot compare these studies. Now, having said all this, I always like to talk about the paradox of randomized controlled trials, and it's very similar to the picture that you're seeing here. A randomized controlled trial is like a meeting as what we are doing today. It's a Zoom meeting with video, wherein you have the best of centers, the best of doctors, the best of patients, patients who have very good performance status, 0 or 1, and they're really seen through before they're enrolled into the study. While the Zoom with audio only is like real world data where all patients come with a baggage, the doctors are different, the setting is different, the hospitals are different in terms of their experiences, and hence that's the paradox of randomized controlled trials, because they are done in a very, very controlled setting, and hence it's very, very important to also look for real world data to see if what you're getting in the randomized controlled trial is actually reproducible in the real world. Now let's look at this case. 78-year-old lady, newly diagnosed de novo metastatic breast cancer, 2 liver metastasis, PS is 2, recent CABG, bypass grafting, which means a creatinine that's up. Histopathology shows an ER positive, HER2 negative breast cancer. 78-year-old, PS2, recent bypass grafting, a creatinine that is 1.8, which will amount to a creatinine clearance of somewhere around 50-55. Does this patient really fit into any one of these studies, the Paloma, the Mona Lisa, or the Monarch? No, this lady would not have fit into the inclusion-exclusion criteria of any of these studies because she had a PS of 2, she had borderline renal function, and she just had a bypass grafting from which she's just recovering. And that's probably one of the reasons that her PSS is not so great. And this is a patient you will not find in any of these studies, but you will find in real world practice. And you cannot tell this lady, you don't belong to the IE criteria of any of these studies, and hence you will not be eligible for the drug. You would still use this drug, but you would be a little cautious. And that's exactly what we did. We started with a Palbo dose of 100 milligram with letrozole. This is the pre-treatment scan on your right extreme, breast, axilla, and the liver metastasis. And in 3 months, you see that this lady tolerated the drug so very well, and all of these have nearly disappeared. And that's the importance of real-world experience. So let me share my experience of 78 patients, which we are updating soon now. So this was a period from Jan 2017 to June 19. The median age was 57. Premenopausal was 1 in 4. Of course, all of them will be rendered postmenopausal. 3 out of every 4 patients were first-line therapy, which means we used an AI with Palbociclib. Now, all of these patients were on Palbociclib. Now, 17% had visceral-only disease, 48% had bone-only, and both was in 35%. Now, almost all of them, 84%, started with a dose of 125 milligram along with the AI. The hormonal therapy partner was letrozole. It was tamoxifen in a very small fraction, and of course, anastrozole in an even smaller fraction. 18% of patients who had resistant disease went on fulvestrant. Now, this is the response rate, bang on what you get in the Paloma study. 55%. 5% had a complete response, 33% had stable disease. So The clinical benefit rate nearly amounts to about 93% here. You can't get better than that. The progression-free survival has not been reached with a median follow-up of about 16 months here. Now, as expected, you will see that the grade 3-4 neutropenia is about 60%. 2 patients had febrile neutropenia, and there was only 1 patient who had an AE-related discontinuation. Now, this is a busy table. This is data from our hospital, our 78 patient. This is the Paloma studies. This is the sensitive and the endocrine resistant group of patients in the first line and second line here. This is another study of patients from South India, and this is North India. Now, you will see that the de novo metastatic disease was higher in our country compared to the patients who went into the Paloma studies. The number of patients with visceral metastasis was quite variable, but the point is that a significant proportion, at least half, if not more, of all of them had visceral metastasis. The overall response rate was at least as good, or if not higher, in the real-world cohort from India compared to what you get in the Paloma studies. The median progression-free survival was not reached because in all of these studies, the follow-up has been short, and same is the case in the second line also. What about toxicity? Again, neutropenia, very similar to what you get on the Paloma studies, between 70 and 80% there. Of course, patients had dose delays and dose reduction. Now, the 16% is dose delay, and 8% had some dose reduction, and that's what you see in all the others. Of course, in a clinical trial, you're looking at patients more closely. You have a set of investigators who have just started using that drug, so you have a little less of an experience during the start of the study, at least. So the dose delays and reductions are a little higher as you see in the pivotal studies, especially with a higher number of patients compared to the real world studies. Okay, so that's the reason why you're seeing this difference in numbers. So summarizing the second part, which is real world data for Palbociclib, this adds to the body of evidence for these very important therapeutic agents in the advanced setting. The real world effectiveness outcomes with Palbociclib complement what has been demonstrated in the clinical trials, and that is with respect to the response rates, the progression-free survival, and of course, with similar toxicity. The reproducibility of data from randomized controlled trials, I think that's a very, very important issue. And this reproducibility adds to our confidence in prescribing Palbociclib and, of course, all the other CDK4/6 inhibitors also. And we also have to remember that with help from social groups, with help from pharma companies, we are now seeing that the access and affordability for these drugs for our patients who are very, very deserving continues to improve. So that brings me to the end of my talk. Be safe, be happy, take care of yourselves, and I will take questions, if any, and try to answer them. Thank you so much, all of you, for that patient hearing.